All right, good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is the role of genetics in epilepsy diagnosis and treatment. And we're pleased to have as our speaker Dr. Danielle Nolan, who is a pediatric epileptologist with the Beaumont Pediatric Comprehensive Epilepsy Center. Dr. Nolan, could you briefly introduce yourself and talk a little bit about your clinical and research interests and describe your experience with this topic?
Sure. Well, thank you for inviting me to participate in this conversation. It's definitely an area of passion for me. So I am a pediatric epileptologist by training, trained at University of Michigan for peds neurology and epilepsy, and then did some additional work at Boston Children's learning about pediatric epilepsy genetics. I'm the founder and director of the Beaumont Pediatric Neurogenetic Testing Clinic. In that clinic, I work on evaluating children with epilepsy as well as other neurologic conditions, trying to help identify an underlying genetic diagnosis for their symptoms.
Okay, great. Well, our understanding of the genetics of epilepsy is rapidly growing, and the role of genetics in diagnosis and treatment continues to evolve. Can you start by explaining the different kinds of genetic changes that can cause or influence diseases like epilepsy?
Sure. There are many different types of genetic changes that can either cause or influence epilepsy. When I'm thinking about the different categories, I like to use the analogy of an encyclopedia. So an encyclopedia is a set of books, and you can think of that in terms of our DNA. So there are chromosomal changes that can cause epilepsy or epilepsy syndrome. This can be akin to missing half of a book in that set of encyclopedia, missing several chapters or several chapters duplicated. Other types of epilepsy syndromes include genetic changes. So again, thinking of that encyclopedia, looking down to the level of a page or a letter on a page in that encyclopedia of our DNA. These are often called channelopathies. Outside of that group of genetic changes, there's also the mitochondrial changes, which can cause epilepsy. That's a whole other set of books. So there's many different types of changes in the genome, which can cause epilepsy, and it just depends on what level you're looking at.
Okay. And just to clarify there, I think a lot of times when people think about genetics, they assume that all genetic changes are inherited, but can you explain what de novo mutations are and kind of talk a little bit more about the distinction between that and hereditary changes?
Yeah, absolutely. That's a good question because it's very frequently brought up by patients when they are referred for genetic testing. They say, well, it's not genetic because nobody in our family has epilepsy. But it is true that most often these genetic changes that are causing seizures can be de novo. So that means that in the process of the child's kind of DNA development, there was a change that was new to them. So genetic doesn't have to mean inherited. Now, there are definitely times when a child can have a genetic epilepsy that they've inherited from a parent who may or may not be affected with epilepsy.
Right, right. And in terms of the types of genetic changes involved in epilepsy, can you kind of give a rough idea of the spectrum of changes from single gene mutations to multifactorial genetic disorders, and kind of talk about what we know about those?
Yeah. So the first category is I kind of like to look at it from a broad spectrum and down to those little parts. So those chromosomal disorders, again, thinking about those missing or duplicated books, that's a broad category of epilepsy. Different chromosomal disorders can cause epilepsy as well as implicate other systemic involvement like cardiac or kidney involvement. But then those monogenetic disorders, so those are the disorders where one letter on one page of your DNA was changed, these include things like SCN1A-related epilepsy. More commonly, that's thought of as a Dravet syndrome, although, different changes can cause different epilepsy syndromes. Another common single gene disorder is the SLC2A1 or GLUT1 deficiency. So that's an epilepsy syndrome, which is caused by one little change in one specific gene in your DNA.
Right.
Those are the two broadest categories, or the most commonly identified categories. However, more and more as we learn about genetic epilepsies, we are identifying that there can be multifactorial or multigenetic reasons for epilepsies, and those are more difficult to ascertain. So you can have several changes in different genes that are all together working and causing epilepsy.
Right. Okay. So let's talk about some statistics regarding genetics and epilepsy. Roughly what percentage of epilepsies have a genetic etiology?
Mm-hmm. This is a answer that is rapidly changing. I think it changes year to year. You go back to 1990, even 2000, and it was estimated that about 20% of epilepsies or childhood epilepsies had a genetic cause. This has significantly changed, and currently I would personally estimate that around 75% of childhood epilepsies, or even more, have an underlying genetic cause.
Wow, that's quite a discrepancy. And is that just simply just that we're learning more about the genes that may be involved?
Yes, exactly. It's just that the technology of finding these causes has rapidly changed. We used to just grossly look at pictures of chromosomes, and now we're sequencing, little base pairs. We have 1 billion base pairs or 1 billion letters of our DNA. And it's only recently that we've been able to have the technology to sequence these and look for letter changes.
Okay, great. So I imagine this number is still, it's obviously much higher than we thought it was, but it's still hard to define because there are some epilepsies that have an exclusively genetic etiology and others that have a combined etiology that includes genetics. Can you talk briefly about the idea, the concept of a combined etiology?
Yes. So the first category is typically those monogeneic. So the things like SCN1A, Dravet, it's epilepsy caused by one gene change. We used to divide epilepsies into genetic epilepsies, structural epilepsies, or trauma or immunologic related epilepsies. Now we're realizing that genetics can play a part in all of these categories. Children with, for instance, lissencephaly or smooth brain would be categorized as structural. However, we now know that there is a genetic reason for those structural changes. Children with immunologic disorders might be placed in a separate category. But again, more recently, as testing has undergone, we realize that there can be genetic reasons that put kids at risk to develop immunologic disorders that may lead to seizures.
Right. So with this in mind, is it safe to say that there may be value in genetic testing even for those who have a type of epilepsy that's not typically considered a genetic epilepsy?
I think that there absolutely is. With children who respond to seizures with their first medication and are doing well, the chances of finding a genetic reason are very low. However, kids who are refractory to medications or have seizures plus other concerns, whether it be neurocognitive or even other parts of their body being involved, having heart problems, having kidney problems, there's definitely a role of genetic testing. Some genetic test results can actually give us an idea of what medication might work best for a child. Other genetic test results may not necessarily change the plan for the child's epilepsy, but give some idea about concerns for the future. In the future, they may be at risk for developed kidney cysts. Other chromosomal disorders that primarily present with epilepsy can have an increased risk for new onset type 1 diabetes. So in any child who I would say is epilepsy plus, so epilepsy plus 2 or more medications, epilepsy plus other health problems, there's definitely a role for genetic testing.
Okay, great. Overall, what's the likelihood of a child developing epilepsy if their parent has it? And how much does this increase if the parent has a type of epilepsy that's known to be genetic?
Mm-hmm. It does vary based off of the etiology or the reason for seizures and the types of seizures. In broad terms, we would say that somebody in the general population is at about a 1% risk for having epilepsy. If you have a first-degree relative with epilepsy, so if there's a child of a parent with epilepsy, in general, that risk increased to about 5%. However, if you can identify the genetic cause of that parent's epilepsy, that risk can be as high as 50% for the child.
Okay. Are there any epilepsy syndromes for which we have even more specific statistics on the likelihood of inheritance?
Mm-hmm. There are specific gene changes that can give you a very good idea about the risk of inheritance. I'm going to use an example of, it has a very long name, but autosomal dominant nocturnal frontal lobe epilepsy. So there are very specific gene changes that we know can cause this type of epilepsy. And not infrequently, this type of epilepsy is diagnosed in either young adulthood or late teenagers, at the point where you're thinking about having kids. If that genetic reason is identified, because it's an autosomal dominant change, meaning you only need one copy to cause seizures, you have 2 gene copies. So if one gene has a change that's the reason for the seizures, you have a 50-50 chance of passing that down to a child. So that's a time when I would say, your risk of having a child who has epilepsy is about 50%. It is a little bit of a funny kind of view on epilepsy genetics right now, because there is a category that we call genetic generalized epilepsies. And these are very common. These are childhood absence epilepsy, juvenile myoclonic epilepsy. In general, we believe that these are genetic. A person is born with a DNA change that is the reason for their seizures. However, we haven't been able to pinpoint down the main gene that causes these epilepsies. And at that point, we believe it is either multifactorial, many gene changes together working to cause seizures, or many different gene changes independently, which can cause the same seizure syndrome. So that case, even though it's called a genetic generalized epilepsy, the risk is still very hard to quantify for a child of that parent, and it can be anywhere from that 5 to 50%.
Right. So epilepsy-related gene mutations are being identified at a rapid pace. Roughly how many have been identified, and about how many epilepsy syndromes have been mapped to specific genes?
Mm-hmm. Again, that's the kind of the point where it's very cool. We're in an age of rapid exploration and identification. So if you had asked me in 2000 how many genes, I would say 7. Asking me now, I would say greater than 200. And truthfully, genes are getting added every day. The reason for this is because of the readily available testing. So now we're able to find different gene changes, and having one person with a gene change doesn't say this is the gene that caused epilepsy. So as we're testing more and more people, finding patterns, that's when we're adding genes to that database. So today, I would say greater than 200. Ask me in a year, and I will have no idea. And in terms of epilepsy syndromes, I would say I can't give you a great number, but at least 50% may have a specific genetic etiology that we have been able to identify, and that is just rapidly growing and changing.
Wow. Okay. So that brings us to genetic testing. Broadly speaking, what are the primary benefits of genetic testing? And under what circumstances do you recommend someone with epilepsy getting it?
Mm-hmm. There are very kind of specific reasons in which I will get testing, and I don't think that it's the right choice for everybody. A child under 3 years of age who is having seizures, I do recommend getting genetic testing just because certain epilepsy syndromes will present that young, and genetic testing may give you an idea of the specific medication that's going to give them the best seizure freedom and the best kind of chance with their development. Other reasons to get genetic testing are those epilepsy plus kids. So children who have epilepsy plus developmental delay, epilepsy plus cognitive impairment. The reason for that is if the testing doesn't change the medication immediately, there are other things that we can learn from a child's DNA. And that goes on in the lines of prognosis. Is this something where other children have had the same gene change and they've outgrown their seizures? Or other children have had the same gene change and have had very refractory seizures? There are those cases that I mentioned that can implicate other systems to look into. There have been cases just in my clinic where I've had a child who had epilepsy. We did a genetic test and found that we should check their kidneys. We checked their kidneys and they were found to have renal cysts. They weren't having any problems yet, but because we were able to know that they were at risk for this problem, we could identify it, and it did change how we managed their overall health for the future, being conscious of the risk for kidney damage in the future with different medications, closely monitoring. So those are the main times when I would get epilepsy and kind of earlier in the road. And then definitely at any case where a child is what we call medically refractory, meaning their epilepsy is not responding to the first one or two medications, I would get genetic testing at that point as well.
Okay. And when we hear about genetic testing, it's most often talked about in the context of pediatric epilepsy. Are there circumstances when adults with epilepsy, even if they didn't develop it as a child, could benefit from genetic testing?
Yes, absolutely. Even though I work in the field of pediatrics, I don't infrequently have referrals from our adult epileptologists as well. I think that that's a population that has been sorely missed in terms of genetic testing, given the recent advancements. There are adults who have significant neurologic concerns, but when they were children, the testing wasn't available. Or when they were children, they might tell you, oh, I had genetic testing and it was negative. We've learned so much since that point. If an adult has refractory epilepsy, they definitely warrant a genetic evaluation. I've had somebody diagnosed with the SCN1A Dravet gene as late as 30 years of life, and finding that diagnosis in this young adult has changed their medication, has improved their seizure freedom even at that point.
That's good to know. So can you talk about the different types of genetic tests available, the differences in what they show, and how patients and families should decide which test to get?
Mm-hmm. So again, many different types of genetic tests, and something that is very important, I think, for families to realize is that there's not one all-inclusive genetic test. I've even had insurance companies deny genetic tests because they say, well, just skip to the end. Get the one test that's going to show you everything. And there's just not a test that does that yet. So it's really a conversation with the provider. Depends on the child's symptoms about which type of test you want to get. A test that would look at the chromosomes as a whole, looking for those chapters deleted, would be a chromosomal microarray. Looking at specific genes, trying to find a small little letter change on one page of their DNA, that would most likely be what's called a gene panel. There are various types of gene panels and various different companies that provide this type of service. So usually the choosing a gene panel is based off of the child's symptoms. You can have an epilepsy gene panel that is very specific, looking at 10 genes or less. You can have a general epilepsy panel that looks at about 180 genes. If a child has epilepsy but also significant other neurodevelopmental concerns, there's neurodevelopmental panels that will look at 800 genes. Often, besides the child's physical presentation, that helps me decide which test to order is unfortunately insurance authorization as well. Thankfully, they're kind of getting on the ball with recognizing how much genetic testing can impact a child's well-being, but sometimes they will refuse one test and approve another. You have to find a genetic testing lab that is in the child's insurance network, obtain prior auth, and it can be a little bit difficult. So it has to be a provider who is willing to put in that work behind the scenes to get the right testing for the child. There are different genetic testing companies who thankfully are recognizing this difficulty and the barrier to the patient's care and providing different programs that help push through genetic testing. Invitae is a company that's offered a behind the seizure panel, so that's a no-cost epilepsy gene panel for patients who fit a specific category. They do that in order to try to identify rare syndromes that may have a specific treatment or be able to participate in research, but it's been a really good resource for patients who otherwise might not be able to get genetic testing.
Great. Have you noticed in general a difference between private insurance and public insurance, like Medicaid versus private insurance in terms of coverage?
I think there has been a little bit of a difference. Private insurance, certain ones may put a hard stop, and I can argue with them till I'm blue in the face and they will never approve it. However, there's times when a private insurance will initially deny it, and then I do a peer-to-peer, explain the reasoning, explain the research behind the testing, and at that point they'll approve it. The Medicare and Medicaid is a little bit hit or miss. Oftentimes they won't approve it, but then there are certain programs through these genetic testing companies that will actually allow these patients to obtain their testing free of charge. So it takes a little bit of legwork trying to find the right fit for each patient.
Right. Do you know if Children's Special Health Care Services assists with out-of-pocket costs that aren't covered by insurance?
It's a good question. I'm not sure if I can answer as a blanket statement. There have definitely been some cases where the insurance has helped, and some cases where it hasn't been applied based off of the genetic testing company.
Sure. Okay. Another test that is mentioned at times is whole exome testing. Can you talk about that and what circumstances that might be appropriate?
Mm-hmm. Yeah, so this is a great test. It's been used in research for several years, but more recently in the last 5 years or so has been really brought to the clinical realm. The name of it is a little bit misleading for some people because they say whole exome sequencing. Oh, this is the test that's going to cover everything, and it doesn't. So it's a test that looks at all of the genes in the person's DNA, all the exons, so genes that we believe are translated into proteins. So not the entire DNA, because there's things called introns that aren't necessarily sequenced with this test, but the exome is the area where we believe most of the gene changes that cause disease are located. It's not all-inclusive, like I mentioned. It may miss small little letter changes. It can miss something that we call triplet repeats, but it's a very good broad test. It is what we call a non-specific gene test, meaning it's something where if you've done some first-line testing and you think that there's a genetic cause for the child's symptoms, but you can't fit it into a box of putting a name on it, this is a good test to go to. It just gives a look at all of the genes and tries to find any letter changes. It's a little bit difficult to interpret the results of this. There can be 3 possible outcomes of any genetic test. There's a negative, meaning you didn't find a gene change in one of the genes that was tested. It doesn't mean that the child's epilepsy is not genetic, it just means that it wasn't identified. There's a positive, meaning you found a gene change in a gene, you know what that gene change does, or you've seen other people with similar symptoms with the same gene change. Now, when you get to whole exome sequencing, the most frequent result is that third kind of result option is the variant of unknown significance, the VUS. So a VUS means that there was a change in a gene that was found on the testing, but at this point, we don't know exactly what that means for the child. It's a gene change that is not described in the database, hasn't been identified in somebody with similar symptoms to that child. Doesn't mean that it's not the cause, just puts you in a little bit of a gray area saying it could be, we need more information. So with whole exome sequencing, you do kind of get these variants of unknown significance more often than those other specific tests. But if you work with a provider and somebody who's knowledgeable with interpreting this test, it can be very helpful. Using whole exome sequencing in patients with epilepsy really has raised our diagnostic rate. Before gene panel testing, before whole exome sequencing, we could find the reason or give somebody a cause of their epilepsy about 5 to 10% of the time. And whole exome sequencing now has raised that diagnostic rate to about 30 to 40% of the time. We can say, here's the gene change. This is most likely why that child has seizures.
Okay. All right. So can you talk a little bit about what the tests involve and how long it typically takes to get results?
Mm-hmm. Absolutely. So depending on the test and depending on where the testing is done, it can be a blood draw. The chromosomal microarray that's looking for chromosomal disorders will often be done through the hospital system because it's a test that's been more commonly used for longer, so most hospitals will perform these, and most often it's a blood draw. The gene panels and even sometimes the whole exome sequencing are often sent out to different genetic testing companies. You can do a blood draw. So there are some children who a blood draw works best for them because it's quick and you know that you can get the sample and you send it out. Other ways to get the testing, though, more recently, we're able to do spit testing, depending on the lab that you use. So we have some where you just have a little tube and you have the child just spit into it, fill it up with spit, you cap it, you mail it off. So it can even be done from home. In this age of COVID, there are times where I'm mailing out a saliva testing kit to the family. They have their child spit in a tube and then they mail it out to the testing company. If the child is not old enough to spit, there are some testing companies who will do buccal swabs. You just swab the inside of the cheek, put that swab in the kit and mail it out. It's a really nice option. The important thing with these is kind of in the process of getting these tests is that insurance authorization. So making sure that before you have the testing done, the provider has done the legwork of getting it authorized, seeing how much it's going to cost the patient. There have been unfortunate times where this step was skipped and the patient is stuck with several $1,000 bill. But if you do get the prior auth beforehand, it can be a kind of a range of a couple of hundred, sometimes free. So that's really beneficial. In terms of turnaround, it does vary based on the test. The chromosomal microarrays, a couple weeks, 4 to 6 weeks. Whole exome sequencing, we used to give a time base of about 4 to 5 months for the results to return. You know, again, that's just a very broad test looking at all of the genes in the DNA. However, as technology has advanced, I've seen whole exome sequencing result in as little as 6 weeks.
Okay. Just another thing that you'd mentioned earlier about the variants of unknown significance. Is there a way that you can kind of flag someone who's received one of those and have something that reminds you, okay, a year from now, let's check the genetic database, so to speak, to see if that's no longer a VUS and is now a known variant? Is there a way to do that?
There should be. So most genetic testing companies for specific tests will reevaluate variants themselves periodically, and then shoot the ordering physician an update if the classification of that variant has changed. But it's not always the case. And it's typically only done once every couple of years, so that can be a delayed and an otherwise diagnostic result. So in my clinic, we do have a kind of HIPAA secured database that we keep of the patient's testing with little flags saying, okay, it was reevaluated at this date, remember to go back at this date and re-explore it. Because it can often fall down to the physician to really keep up to date on that, and looking through the database, it may be something as one paper was published in PubMed that the testing company missed, but can give you an idea that, hey, maybe this VUS, this unknown change, is actually the reason for the child's epilepsy.
Right. Okay. Are there any epilepsy syndromes that require genetic testing in order to make a diagnosis, or do findings simply help to kind of increase your confidence in the diagnosis?
Mm-hmm. I don't think that there's one that's absolutely required for the diagnosis. Epilepsy in itself is a clinical diagnosis, and there are times where you know that a child has epilepsy, but you cannot find a genetic reason for that. But it is important because it can, like I said, guide treatment. It can confirm the diagnosis. For instance, there's a category, Tuberous Sclerosis complex. So that's a genetic epilepsy that has many implications. If you only have a child with one symptom, you would really want to know if they have TS. And so in order to make that firm genetic diagnosis, genetic testing is very important. But even in that, about 10% of patients with the clinical diagnosis of TS-related epilepsy, even if you did the testing, you still may not find that genetic reason.
Okay. Are there ways for patients, families, and clinicians to share de-identified genetic testing results for the purposes of research?
Yes, there are. There are many different genetic testing registry databases. Some of the genetic testing companies like GeneDx, Ambry, and Vitae may submit these variants, these gene changes, without any patient identifying information to national databases, things that are available like ClinVar through the NIH. There's also more kind of private or localized registries within different hospital research settings. And sometimes even these genetic results may come to you, and at the end they say, oh, this variant, even though it's a VUS, you may want to consider enrolling the patient or sending the de-identified information to this specific database at a researcher's lab. So there's a lot of broad testing registries, but also some more specific variant testing registries as well.
Okay. Is that typically incumbent on the parent or the patient to find out about those or to research those, or is that if there's a good place where that particular information from their genetic test could be beneficial, is that something that an epileptologist or the gene testing company itself might reach out to the parent directly?
Yeah, depending on the gene testing company, they may just do it independently. Given that it's de-identified information, it's helpful for them to have that information because it can clarify other testing results, so they may just do it themselves. However, the more specific variant testing often is left up to, I would say, the ordering physician, so whether it be an epileptologist or a primary neurologist, to look into that and look into it a little bit more and say, is there a testing or a variant registry that should be entered? Or is there something that I should have my patients look into? So there's not a clear guideline about how that is accomplished. As testing becomes more available, it's often kind of forgot about because, understandably, the person that ordered it is focused on the child's treatment.
Right. So ultimately, we hope that continued research into the genetics of epilepsy and other health conditions will lead to an increase in precision medicine. And this is where the results of genetic testing, along with big data and other patient diagnostic information, can help physicians to tailor treatments to individual patients to maximize their effectiveness. Can you give a few examples of specific genetic findings that help guide clinicians to specific epilepsy treatment choices?
Absolutely. So the initial one that most people think about is SCN1A. That's a gene that can cause a wide range of epilepsy presentations. However, when you diagnose somebody with SCN1A, you automatically know that you need to actually avoid certain medications, avoiding the sodium channel blockers like lamotrigine or phenytoin. Those sodium channel genes really give us an idea about medication treatment. So where SCN1A, you want to avoid those medications. If there's an SCN2A or SCN8A gene variant, high-dose dilantin or phenytoin may actually be helpful and not otherwise thought about as a treatment for a child. SLC2A1 is also a common one that's thought about in terms of epilepsy genetics. This having a pathogenic or a change in this gene that is definitely the cause of child's epilepsy says, okay, at this point, you stop the trial and error with medications and go right to the ketogenic diet because that's going to be the child's best bet for epilepsy or seizure improvement. Even more, there can be things like a POLG, P-O-L-G, gene change that says if a child has this gene change, you might want to avoid Depakote because there are rare cases of irreversible liver failure. So some genetic testing results can be very significant for medication choices in children.
Okay. Do you foresee this being at the rate that we're currently going? Are there going to be more and more of these cases where we can know to specifically avoid a certain treatment or know to that this particular treatment is going to be more beneficial? Can you talk a little bit about the trajectory of this in terms of precision medicine?
Mm-hmm. Yes, I do think that as we test more people, we're going to learn more and more. So these genes that I mentioned were the first genes identified for epilepsy. So therefore, we tested more children for them. We have a very broad database of children who have these gene chains, and we have the benefit of looking back at their course and saying, okay, they didn't do well with this medication. Let's confirm in cellular studies that the medication doesn't do well with the gene change, and then we can make these broad recommendations. But more and more with the advent of whole exome sequencing, we're identifying new gene changes that we're still learning about. So an epilepsy genetic syndrome right now may only have 5 children identified. So we can look at those 5 children and say, okay, these are the meds that are on, this is what has worked or what has not. But it doesn't really give much weight for the next child with a genetic syndrome. Give it 5 years, and we may have identified over 200 children with that same genetic syndrome. That's a much better group to say, okay, what has worked for them, what hasn't. We can put that gene change in a cell, test the theory of which medication works and what doesn't, and really give much better guidelines. So I do anticipate that over the next 5 to 10 years, the precision medicine for these genetic epilepsies is just going to explode by virtue of testing patients.
Great. Do you have you heard of, or do you anticipate that pharmaceutical companies will start to actually look at specific genetic mutations associated with epilepsy or even other diseases and try to develop medications that specifically target a genetic mutation?
Mm-hmm. Absolutely. There's already been the start of this that we have seen in research. Most right now, the research that's going on is at the cellular or animal kind of model. A good example of this is children with Rett syndrome or MECP2 related neurodevelopmental disorder, which is often associated with seizures. Many researchers have taken this genetic syndrome. We've identified the cause of it. we can identify which protein or where the problem is on the terms of a cellular level. And there are several research projects kind of targeting that direct pathway in order to improve the outcome for children. Another example is the tuberous sclerosis complex. So that's two gene changes that we know independently can cause a seizure or can cause tuberous sclerosis that leads to seizure. And companies have said, okay, now that we know where the problem is on the pathway, we can direct a medication to that pathway. Those are the mTOR inhibitors to try to precision alleviate those genetic symptoms, the symptoms that result from their genetic epilepsy. Just even a brief kind of look into the field this morning, there's already been 4 other genetic epilepsy targets that specific research companies are working on, with SCN1A is primed to have a precision medication, but also they're looking at UBE3A, which can cause Angelman syndrome, or NPC1, which can cause a type of Niemann-Pick disorder. So there's already research in this realm. It's just kind of new, it's on the advent, but I do believe that we're on the cusp of having more specific precision medication.
Great, great. Will there be forms of precision medicine available to those whose epilepsy does not have a genetic cause? And if so, what types of information will that rely upon?
That's a good question. So for epilepsy that do not have a genetic cause, at that point you're thinking about, more things like a trauma, or even, again, going back to those autoimmune disorders you may think of as not having a genetic cause, although I believe that most likely there's a genetic reason that people are more at risk for those things. Right. But I don't know if there's going to be a specific precision medication option for those people. It will be more based off of symptoms, because you can't say that there's one pathway that's necessarily leading to the same symptoms in children without a genetic cause. Right.
So can you give a few examples of situations in which genetic counseling may be warranted?
Mm-hmm. Absolutely. This is something that I think is very, very important when we're talking about genetic testing in children. It's easy enough, like I had mentioned earlier, to get the testing. You get insurance authorization, you spit in a tube, you test the genetics, easy. But there are a lot of outcomes that you may not think about when you're doing genetic testing in children. There are cases where we have to test the parents for different gene changes found in their children. And there are cases where kind of maybe information that wasn't known to the child or wasn't known to one of the parents come out, such as non-paternity, finding out that that child is not related to who they thought was the biologic father. So this is important information to know that the parents should be aware of prior to getting genetic testing for their children. When you think about whole exome sequencing, you're looking at all the genes in a person's DNA. This includes things like BRCA, BRCA1, which can say you're at increased risk for breast cancer, genes that say you're at increased risk for Alzheimer's. And if you're getting that testing as a parent, you're making the decision for your child for them to have this information. So it's something that should be discussed with a genetic counselor, that the parent should be fully aware of. It's a lot of responsibility. So all of these outcomes that as neurologists we may not really think about are very important and something that genetic counselors do a great job of walking parents through.
And in general, for an adult, a woman with epilepsy who is considering having a child, do you generally recommend genetic testing and possibly genetic counseling for all women of childbearing age who are seeking to have a child, or only those who have a known genetic epilepsy? I guess how do you advise women who are considering pregnancy?
Yeah, I think that for women who are considering pregnancy, there should definitely be, if anything, a discussion with a genetic counselor. So a discussion about what are they looking for in the genetic testing. Are you looking to say this is exactly what my risk of having a child who has epilepsy is? Because that might not be what your expected outcome is, depending on how severe or the different features of the woman's epilepsy. You can find things that you might not want to know in terms of genetic testing. Some people say, I want to know everything. I want to be prepared for every possible outcome. But even if we have that information, it's important to know that that doesn't mean that we're guaranteeing the outcome. We're saying that you're at risk to have a child with this. That doesn't mean that you are going to have a child with that. It just gives you risks. And that can be a lot of overwhelming information, can change family planning drastically. So before any testing is done, it should be definitely a conversation about what you expect from the outcomes.
That makes sense, yeah. Can you explain what epigenetics refers to and share any possible role that it may have in the development of epilepsy?
Mm-hmm. Epigenetics is a very broad term for an exciting field that can be a little bit difficult to explain. To do that, I want to go back to that analogy of the encyclopedia. So again, you think about the encyclopedia of your DNA, a set of books that contain chapters and pages and letters, all of your genetic information. So when you read a book, you have letters and they form a sentence. That's what we think of typical genetic testing. When you get to epigenetics, it's the expression of the genes as opposed to the spelling of the genes. So you could read the same sentence, but if you use a different tone, it drastically changes the function of that sentence. And that's kind of how epigenetics is. So it's the expression of the gene change, or the expression of genes. There are different, in order to get from gene to protein to function, there's a lot of different steps. So even if you screen the DNA and everything is in order, if something down the road is changed, a protein is changed, or there's a methylation, which is almost like a little hiccup in the DNA, it can then lead to seizures, and that wouldn't be caught with traditional genetic testing. There's a lot of research in this area, and at this point, that's what it is. It is research. But I think that's going to be kind of our next phase of discovery in terms of really learning about why somebody has epilepsy and how that process develops.
Okay. And what typically just is it proteins that turn on or turn off or alter the expression of genes, or is it other chemicals? I guess or is it kind of all of the above? There's a lot of different ways.
It's really all of the above.
Yeah.
So there's methylation, which is almost like a little chemical. So there's methylation PCR testing specifically for the syndromes of Angelman and Prader-Willi. So depending on where the methylation is and who you inherited it from, it can cause different neurogenetic syndromes. So that's an example of epigenetics. And then down the road, exactly, it can be anything. It can be a protein, just a change in a structure of a chemical. And this is really an area that's prime for exploration, but is still very much unknown.
And can epigenetics, epigenetic changes, I guess, occur at any time in life? Or and can they be influenced by environmental factors, like there's some sort of environmental change, or that then triggers a sequence of chemical changes that then turns on or turns off or alters the expression of a gene?
Mm-hmm. Yes, absolutely. I think that if there is going to be a change in the genome, it's going to be more often early on in life or prior to birth, but there is a chance. We know that there are certain things that can denature DNA or break it down, and then when DNA is forming, there's always a chance that there can be a little hiccup in how it replicates. And things can definitely influence that, like environmental factors, toxins, et cetera.
Okay. Are there any treatment options being studied or in development that target the epigenome as a mechanism of action, or are we you mentioned we're kind of in the research stage, so right now I'm assuming there's no current treatment options that target that?
Not specifically. More right now, there's a lot of focus on disease-modifying approach using specific gene therapy. So trying to insert genetic DNA that will then lead to the appropriate protein, as opposed to modifying the protein down the road. You think about, SMN and sickle cell disease. These have been in the news lately because they've had gene therapies. And that's really what research right now is focused on.
Okay. And can you talk a little bit more about gene therapies and viral vectors and, how that works in general?
Yeah, absolutely. So it's a very exciting time in terms of research of these things. So a viral vector is really using viral DNA. So the most common is the adenovirus. Viral DNA is a lot simpler than human DNA. It's kind of thought of as a circle. So just a circle of letters and numbers, base pairs that the virus replicates and infects a host. So with viral vectors, what researchers are doing is using the adenovirus DNA and then inserting the correct gene sequence that may lead to the production of a protein that is otherwise missing in somebody with a genetic epilepsy. And so if you can insert that gene sequence into the adenovirus DNA, then you inject that into the person, and the hope is that the person's own cellular mechanisms will take up that virus and replicate it, just like it would for somebody who's infected with a viral illness. But instead of producing proteins for the virus, it produces that protein from the DNA that was inserted and otherwise missing. It's a very exciting field of research, and there's many different kind of studies that are ongoing. There's MECP2 has just recently started a few very limited clinical trials, but there have been some exciting outcomes. That's kind of the first one in terms of any sort of epilepsy clinical gene therapy trials. A lot of them are currently still in the lab, still in cells, but showing promise.
Right. And did you mention that one of the latest therapies for sickle cell involves gene therapies?
Yeah, they're most recently, I can't remember when it was, several months ago, there was a young woman who had sickle cell and was treated with gene therapy, and they've shown significant improvement in her seizures and her level of that protein.
Yeah, I remember watching a show about it. It was pretty amazing. So,
yeah, it seems like science fiction, but I think that we are getting into that realm of science fiction. Epilepsies are going to be a little bit harder because whereas for sickle cell, if the protein is replicated in the blood, you're great. But for epilepsy, we need the vector to cross the blood-brain barrier and get into the brain. And that's why I think that it's going to lag behind a little bit. It's got a few more hiccups to get through, but I'm still hopeful.
Mm-hmm. And with viral vectors, do you need to then also be concerned with somehow stopping the body's immune response so that the viral vectors can, result in their intended effect?
Yeah, exactly, because your body's constantly fighting off different viruses, so you have to try to get your body not to fight off the viral vector, and that's another hurdle that these researchers are working on crossing. Right.
So are there any areas in the field of genetics and epilepsy that we haven't discussed yet that you think people should know about?
No, I think we covered a lot of it. I think that it's important for people when they think about this topic to know that it's very promising, very exciting, but also still in its infancy. So going into genetic testing, you shouldn't necessarily expect it to drastically change your world or change that child's life. At this point, if you can find one of those few gene changes that give a direct clinical change, that's great. But more often than not right now, it's an information process. We're gathering data to help push things forward for the future.
Okay, great. Well, if we don't have anything else that we want to bring up, I guess we'll go ahead and open it up for questions and discussion. Okay, who would like to get started with a question?
I would.
Go ahead.
My name is Nancy Exome, and I was wondering, this was great information, but it was just going too fast for me. Is it possible to have a transcript of this discussion?
We're not going to have a transcript, but we will have a recording. So that will be uploaded probably early next week. It'll be available on our website and our YouTube channel, so you can listen again and pause as needed and look stuff up if you need to, and hopefully that'll help with any things that you need a little clarification on. And of course, if you want to contact us directly with any questions about anything that you learned today, I'm happy to help with trying to provide any clarification.
Thank you.
Yep. Other questions?
And I just want to jump in about that last question.
Yeah.
It's definitely true that this topic can be confusing and overwhelming. And it's because it's so new, but also because there's different implications depending on each person's specific questions and symptoms. So if you have any questions or you're just curious about it, it's great to just start that conversation with the neurologist, because they can give you more detailed information that may be specific to you. It's not infrequent that I have people refer to me, not necessarily to do the testing, but just to discuss it and see if it's the right choice for them.
Okay.
If I could ask a question, please.
Yep.
My name is Kathy, and my daughter has juvenile myoclonic epilepsy. And JME is kind of interesting because it doesn't even present itself until you're a juvenile. So with this genetic testing, is there information that can help patients who have JME?
Mm-hmm. That's a great question. So JME is in the category of those epilepsies that we broadly call genetic generalized epilepsy, meaning even though it presents later, we do believe that there's an underlying genetic reason for the seizures. However, it's also frustrating because we haven't identified one gene change that causes all JME. There have been a few genetic changes that we can say maybe, but most often they don't change the medication treatment of JME. But if it's more of a family planning question, it can be a useful discussion with your doctor to look at a gene panel.
Thank you very much.
Okay, other questions?
Hi, yes, this is this is Lucas Sun from UCB Pharma. Thank you for taking your time today to present to us. I appreciate it. Just a quick question about genetic testing. Generally, how long does that take to get results? How long is the process, and what is the cost for the lab versus the patient?
Mm-hmm. So the result turnaround does depend on which test you're ordering. So if it's something like a chromosomal microarray, that's typically done in-house in the hospital, and can take just a couple of weeks, all the way down to whole exome sequencing, which can take a couple of months. At that point, the cost is also widely variable. So I have seen whole genome sequencing or whole exome sequencing with an estimated cost of $10,000, even as far as several months or like a couple of years ago. But then genetic testing companies will work with insurance, and we can get that cost down sometimes from $10,000 or from several $1,000s initially down to a couple $100 for the patient.
Okay, awesome. Thank you very much. I appreciate it.
You're welcome.
Okay, other questions?
I have one more.
Go ahead.
Is it unusual for a child to show first symptoms of seizures as a toddler or even an infant and reach the age of 11 and the exact type of epilepsy still has not been identified?
Mm-hmm. Unfortunately, I don't think that that's uncommon. A lot of factors can go into the part of diagnosis. Diagnosis for the type of epilepsy can be a clinical diagnosis, saying they have myoclonic epilepsy. All that means is they have a specific type of seizure, and so therefore that's the type of epilepsy they have. Now, if you're trying to figure out a genetic reason, it also can be a very long process, and even with all of the new advances in genetic testing, we're still unable to say the exact reason or the exact genetic epilepsy diagnosis in about 50% of kids.
So if the seizures seem to be getting worse, even on medication, and they haven't really found anything yet or tried anything yet that really controls them better, you're saying that that's just the process?
Well, if the seizures are getting worse and not being controlled with medication, I would definitely make sure that that child has had genetic testing. And it's important to make sure that they've had all of the genetic testing too, because sometimes, depending on the type of physician you're seeing, they may do the first line genetic testing and then stop.
May I just interrupt for a minute? She is in the process of genetic testing, but she got as far as a simple blood test, but it's the insurance companies that are resisting any further genetic testing at all.
Mm-hmm. Yeah, it's very frustrating. I have long conversations with insurances. I actually have fairly good outcomes with those because as one insurance person told me that I just wouldn't stop talking, so he approved it. And it's really because insurances don't understand it.
Yes.
So there are times where you can just bang your head against a brick wall and you still cannot get the insurance to approve it. Depending on the type of testing, you can sometimes reach out to the lab that would otherwise be performing it and work out a payment plan or a reduced rate. But sometimes even that, you can't do anything about it. It's very frustrating.
Yes, thank you.
Yeah.
And I would just add to that, any cases where someone is having or has drug-resistant epilepsy, they've failed to get complete control of their seizures after 2 appropriate medication trials. Just to reiterate, we always recommend if you haven't already that you see an epileptologist at a comprehensive epilepsy center to then, you can then look at things like genetic testing. You can look at doing additional diagnostic tests like stay in the epilepsy monitoring unit or video EEG monitoring, and then also starting to explore other treatment options besides medication. So.
Okay, thank you.
I had a question. Are there any foundations, any charities that can help offset the cost? I would think the Epilepsy Foundation should have something of the sort, but if not, are you aware of any other charities that can help offset the cost for this? Thank you.
Well, I know unfortunately the Epilepsy Foundation does not have specific funding set aside for that. I wish we did. But on the state level and also on the national level, I don't believe there is any funding for that through the Epilepsy Foundation. There may be some affiliates or chapters in certain states that have some money that is set aside for medication assistance or transportation assistance. I've heard of a few affiliates attempting to do some of that, but I know there are foundations like Danny did and Josh Provides and some other Chelsea Hutchinson Foundation or some other foundations that specifically help with seizure response dogs, or they can help with getting seizure alert and detection devices. I'm not sure if they assist with genetic testing costs, but I think those would be charities that I would at least check out and see if they might be able to assist with that. Dr. Nolan, are you aware of any?
No, unfortunately, I'm not aware of any either. At Beaumont, we do have our patient assistance fund that I have once or twice implored to help cover genetic testing. It frequently is denied, but occasionally I have been able to obtain some funds. Usually it's a couple $100s that may offset at least the cost of testing for patients. But beyond that, I don't know of any foundations.
Yeah, and I would mention Children's Special Healthcare Services as well, just for children as a potential option. Again, as Dr. Nolan suggested, it may not be in every case, but it would at least be something you would want to check with. And again, any child with epilepsy is eligible for Children's Special Healthcare Services, so that would be another thing to check into. Other questions? So something related, it's not really related to genetic testing, but another thing that you might explore if someone has drug-resistant epilepsy and that could potentially help would be testing for autoimmune epilepsy. Can you talk briefly about that and situations under which someone might want to explore autoimmune testing?
Mm-hmm. Yes, definitely. So it's a little bit similar to the category of reasons for genetic testing in that when somebody has seizures who are not responding to the first or the second medication. And for autoimmune epilepsies, they're more often to be a very explosive onset. So typically, in terms of non-autoimmune epilepsies, the child develops seizures. They occur, once a month or start having absence seizures a couple of times a day. But more typically, autoimmune epilepsies start and then just rapidly escalate. They're not infrequently also associated with behavioral changes, erratic behavior, and things like that. It's tested for in a different way. So it's blood work and can be a different panel that may be sent out, an autoimmune encephalopathy or encephalitis panel. And those are important also to identify or to think about because they can have different treatments. Things like steroids or IVIG may be a treatment for an epilepsy that would be considered sooner if an autoimmune cause is identified.
And is that fairly rare that someone with drug-resistant epilepsy is found to have autoimmune epilepsy, or more common than you might think?
I would say it's still fairly rare. We're still learning a lot about it, but it is fairly rare, and it's not typically that somebody would have epilepsy for several years and then you're diagnosed with it. It's usually that the epilepsy and the clinical picture escalates to the point where you are doing all of the testing and you find it within a couple of months. But if you don't think about it, then you don't find it.
Right. Okay. Other questions?
Hi. This is Lucas again. Could you reiterate the part about, I think it was how a genetic mutation depending on the mechanism of action for an anticonvulsant, that you shouldn't take that particular anticonvulsant with certain mutations. Is that correct?
Yeah, so the category that is most often thought about is sodium channel genes. So there are specific genes that control the sodium channel, which is very important in terms of brain electricity. So if you have a specific gene change in the SCN1A gene, and that's the reason for your seizures, at that point you know that you should avoid medications that alter that sodium channel, such as lamotrigine or dilantin. And on the converse, there's SCN2A, which is a sodium channel gene. And if you have a gene change in that is the cause of your seizures, we may consider actually those sodium channel genes such as dilantin because they alter the pharmacokinetics and better help control seizures.
Okay, gotcha. And then are these, so the SBN1A, is that how it plays a role in sodium, in like the sodium channel is that, does it change the conformation? So it's allowing the sodium to flow in and the potassium, the chloride to flow out, even though the sodium channel agent is supposed to close the conformation or slow down the conformation of the sodium channel?
Yep, so it's SC, C as in cat, N as in Nancy, 1A. It changes the function of the sodium channel. So whether it's a low sodium or a fast sodium channel, it changes how that sodium flows along the channel and thereby alters the propagation of the electricity. So if that is altered, then that leads to seizures.
Oh, okay, awesome. Thank you.
Yeah, so I know we have someone, I believe it was Julie on the call, who's a genetic counselor from Beaumont. Is that you, Julie?
Yes.
Yeah, did you have any thoughts that you wanted to share just as a genetic counselor to kind of add to what we discussed during our conversation?
Well, I work closely with Dr. Nolan. In fact, we share an office much of the time. So very much what she is saying is what I would be saying as well. I think it was a lot of great information, and I don't think I have anything specific to add except the one thing that I would say is I also have a background in prenatal genetics, and we would get referrals of a lot of patients that were on seizure medications just to talk about the effects of the medications potentially on a fetus. And so that would be another reason for women who are pregnant or considering pregnancy to seek genetic counseling prior to pregnancy, ideally, just to talk about not only the genetics of epilepsy, but also the effects of the medication. That's all of it.
Okay. So yeah, even though it's not, the effects of medication may not be directly related to genes, it's something that because you talk about pregnancy and having children a lot in counseling patients, that you've learned a lot about that and can counsel in those areas as well.
Correct. So yes, a prenatal genetics center would be a great place to refer a patient who is on medication and contemplating pregnancy.
Great. Well, thank you. Does anyone else have any comments you would like to share or on having had genetic testing, for example, and being particularly helpful, or anyone had any experiences with finding out information that you didn't necessarily expect to find through genetic testing? Does anyone have any comments that you would like to share?
I just wanted to say that my granddaughter's seizure condition, we were told, would increase with puberty, and they were right on with that. So is that a common issue?
There are definitely types of epilepsy which can increase during puberty. Not all of them, but there are definitely some that can, and that can be common due to the hormonal changes that are going on at that time.
Okay, thank you.
Okay, other questions or comments? Dr. Nolan, is there anything, so we've kind of talked about the near horizon for genetics and research, and is there anything on the far horizon, is way out there that you know, think may be happening in 10 to 20 years as opposed to, 5 to 10 years?
Yeah. When I think of the 5 to 10 year outlook, I'm really excited, and I think there's promising therapies. Looking beyond that, it's a little bit intimidating. When you get into genetics, you can think down the rabbit hole and thinking about preventing people from having these types of epilepsy syndromes, and that's a little bit of a intimidating outlook. So I like to kind of temper my thoughts about it and focus on treatment. And just hope that we go along the right pathway. So I think that there's a lot of potential for the future, and it will be interesting to think how things develop.
Yes. Do specialists who use genetic testing a lot, do you have like bioethicists that you can consult with, or what, to again, thinking of the future when maybe genetic testing, maybe you may get information and then have ethical dilemmas as to what you do with that information. Is that something that most epilepsy centers or other institutions that do a lot of genetic testing, do they, employ or consult with bioethicists ever discuss these things?
Yeah. I've had experience in more than 3 epilepsy centers or hospitals, and I haven't heard of that in any of these centers, including very large centers. I think that it's definitely a good idea and something that may be coming in the future. There's ethics panels, but more often that's reviewing terms of treatment and futility, but not these kind of newer questions about genetic testing. So that may be something in the future that will become more commonplace.
Okay. All right. Any other questions? If not, we can wrap it up. I just want to make sure everyone has a chance to share their thoughts or questions. All right. Well, I want to thank everyone for joining us today. And thank you so much, Dr. Nolan, for a very thorough and enlightening conversation. Again, this is being recorded and will be added to our website, so people can feel free to listen to this in the future or share with others who might benefit from it. And again, we hope you can join us for our next Learn and Share conference call next month. And if anyone has any questions, please don't hesitate to call us at 1-800-377-6226 or visit our website at epilepsymichigan.org. Thanks again, Dr. Nolan, and thanks everyone for joining us today.
Thank you for having me. Everyone have a good day.
Thank you. You too. Goodbye.